and welcome to the Evidence-Based Exercise Rehabilitation and Sport Performance channel. This channel is for the healthcare movement professional looking to incorporate applied research concepts into their current practice setting. Today's topic, interlimb coupling. The objectives of this discussion are to discuss the reported outcomes resulting from the performance of interlimb coupling and provide a means by which you can utilize an interlimb coupling training strategy into your own programming and/or setting. Today, we'll be highlighting reported outcomes by Huang and Ferris that relate to the unique neuromuscular control strategies utilized by the CNS between ipsilateral upper and lower limbs. Please note, there are additional outcomes performed in this study that we'll not be discussing due to time or topic content. In accordance to the Oxford Center for Evidence-Based Medicine, this is an observational study and falls under the category of Level 2 evidence. So let's take a closer look into this study. To summarize things, I've taken and extracted the programming components that were utilized. You'll see that we had 16 healthy female participants between the ages of 18 and 29 years. Recordings were performed using surface EMG. In the upper extremity, the muscles recorded were the anterior and posterior deltoid, biceps brachii, and triceps. In the lower extremity, we had the vastus medialis, medial hamstrings, tibialis anterior, and soleus muscles. The authors used an interlimb coupling strategy. This was observed on a computer-controlled recumbent stepper. There were two protocols. First protocol involved utilizing an upper limb effort with the lower extremity remaining passive. The second was utilizing a lower limb effort with the upper extremity remaining passive. Each individual was asked to perform a maximal voluntary effort for one set over 6 to 8 complete stride cycles. They had 1 minute rest between the two protocols, and this design took approximately 15 seconds of data. So statistically, what do we find here? A significant increase in muscle activation of the passive lower limbs took place during active upper limb movement as compared to passive. Next, a significant increase in muscle activation of the passive upper limbs took place during active lower limb movement as compared to passive. So we're noticing that the area that is being increased in activation and is not moving is getting that activation through active movement of the same side limb. And lastly, significantly greater activation was observed on the ipsilateral versus the contralateral side during movement. Now, for those of you who typically skip the stats section in an article, I'd like to help you make more sense of this information from a clinical application standpoint. Let's begin with power. Power can be defined as having a sample size that is adequate to detect a difference when in reality a difference actually exists. In this example, the authors found that there was several statistical differences between the outcomes. That tells you that your power was sufficient. Remember, power is representative of the greater population. If your sample size is too small, the ability to detect a difference when a true difference actually exists will be diminished. A power reported at 0.8 or higher is generally accepted. Let's move on to effect size. The effect sizes of this study were not reported. Since a statistical significance was observed, we can state that using passive motion to achieve interlimb coupling will not result in the same amount of ipsilateral muscular activation when compared to using active range of motion. What a reported effect size would help us understand is the magnitude or size of this difference. And lastly, the 95% confidence intervals. These two were not reported. The 95% CIs would provide us with a range of scores pertaining to the level of activation increase that we could estimate the greater population would fall into 95% of the time. This assumes that we're working under the same conditions, parameters, provided to the same types of individuals with the same demographics. A working range provides the clinician with how much variance they could potentially expect when interlimb coupling is applied to the greater population. Now for the good stuff. Clinical gems!
Yay, yay!
All right.
So, what clinical gems are we walking away with today? Let's have a look at the evidence-based truths this article provides. Number 1, the nervous system naturally prefers in-phase movements of ipsilateral limbs rather than anti-phase movements. During in-phase movements, both extremities move in a mirror symmetrical pattern with respect to the body midline, while during anti-phase movements, these patterns are activated in an alternating fashion. Coupling of the muscular activation occurs between upper and lower limbs. We'll see that this takes place more on the ipsilateral than the contralateral side of the movement being performed. The study also showed us that this phenomenon is bidirectional. It can go from the head to toe or toes to head. And lastly, to get the results that they did in this study, these individuals asked the participants to provide a maximal voluntary effort. So now that we've learned these truths, what type of strategies can we use to apply these to the body? First, let's take a look at the type of movement. We want to use active range of motion as opposed to passive, based off of what we saw in our study here. Next, if we're using this for the purposes of motor re-education, sometimes we have to add more stability into the movement pattern that we're providing the individual in order for them to successfully move through that specific range of motion. Once they have it, then we can make it harder by removing the stability. So maybe we start easier and go to harder here. Next, this goes along with the previous one. Do we want to use isolated patterns or do we want to use compound type patterns? Again, what is our goal? If the person cannot control a compound type movement, we need to start simpler with more stability in an isolation type manner in order to help that nervous system rebuild the connection that it needs. Once it has that, then we can gradually move to compound and in and out of phase type movements. Next, we learn that we will get a good ipsilateral transfer on the same side, whether it's arm movement to leg movement, ankle movement to wrist movement, whatever it is, however you want to apply it there. Keep in mind that you will get more ipsilateral transfer as opposed to contralateral. You will get contralateral transfer though. It's not that you won't get any, it's that you will get a greater amount of ipsilateral. Make sure that the effort level is appropriate and the individual is giving you a maximal voluntary effort to the point to where the movement pattern is being done correctly and accurately. And then lastly, you have your stacking effect. How else could we make this interlimb coupling work better with the other types of treatments that we use? If you're a manual therapist, what else could you throw in there? If you're a modality user, what kind of things can you throw in there to help your individual be more successful when you are applying this specific interlimb coupling strategy? Now lastly, a quick moment of reflection here. You got to make sure that you're having an understanding of what these new truths can and cannot give you. We've gone through that pretty thoroughly in this video. So make sure that you're just not randomly applying this to any of your clients or patients. Have a reason for doing it. Design with a purpose. In order to determine how effective utilizing this is for the individuals that we're working with, you need to have some kind of measurable outcome that helps you assess your clinical effectiveness. And then lastly, how is all this programming going to help you and your patient work towards the greater goals that you have designed for them? Here at the channel, we're dedicated to establish and foster a positive interprofessional environment in which learning can occur regardless of your profession and or previous training. If you've used this type of approach with success, let us know in the comments below. Please help spread the word to your healthcare movement colleagues looking to incorporate more evidence-based training research application into their own practice. As always, if you like what you see here, please subscribe and join our YouTube channel community, where the number one goal is improving the lives of those we serve. A big thanks for hanging out with us today. See you in the next video.